Okay, I think it's time to start. So I would like to start by saying good day to everyone joining from all over the continent. And before we start, I would just like to share some general housekeeping rules. So I would like to request that everyone please keep their speakers on mute throughout, and that you do not put up your hand to ask any questions during the presentation, but pop them into the chat box, and then we will address them during the question and answer session at the end of the presentation. So we will start today with a study startup by Dr. Shaun Wasserman, one of the co-PIs on REVIVE, and that'll be followed by an introduction to our speaker of the day, that is Professor Graeme Meintjes, presenting the highlights from CROI 2025. So I'd like to ask Dr. Wasserman to start.
Thanks, Elsa. Hi, everyone. If we can go on to the next slide, please. So to those of you that are not part of the REVIVE network, welcome. And to those that are in the REVIVE network, welcome to our monthly seminar. It's great to see so many people joining. As per our tradition, I'm just going to give a very brief overview of the REVIVE trial and tell you about the updated numbers that we have as of yesterday. So the REVIVE trial is seeking to answer a very simple and specific question. That is, does azithromycin prophylaxis reduce mortality for people with advanced HIV? It is a pragmatic trial run in ART programs across Africa. It's double-blinded, and patients are randomized to receive either placebo or azithromycin 250 milligrams a day. The patients that are in the trial are those that are adults and have CD4 counts less than 100 and are not suffering from an acute illness. After a month of therapy, of the trial therapy, it's stopped and it's provided, of course, on a background of routine care, which includes ART and whatever else is evidence-based for people with advanced HIV, cotrimoxazole prophylaxis, TB preventive therapy, and cryptococcal screening. And patients are followed up in the trial for 48 weeks, but the primary outcome is determined at 6 months after entering the trial, and that is all-cause mortality. And we hypothesize that azithromycin compared to placebo will reduce mortality in this group. Next slide. So the trial is big. To answer this question, we're looking for an effect size of a 20% reduction in overall mortality. We need 8,000 patients to do that. And the network is growing every single month, which we're very excited about. There are now 9 countries that are active enrolling patients in the trial, 45 active sites, and our target is 14 countries with 62 sites, with new sites and countries joining regularly. Next slide. So far, the team has enrolled, next slide, please, has randomized over 2,300 patients, which is an incredible achievement. And those people that are on the call that are part of the REVIVE network, congratulations. It's really phenomenal work, especially under more and more trying times with the withdrawal of US funding. Every single month in the last 30 days, 250 patients have been randomized. This has dropped slightly from around 300 because of the Easter holidays, but all sites are making fantastic contributions, as you can see here. Next slide. And it shows in this recruitment projection curve, the green background of the number of sites that get activated. The blue straight line is the target recruitment rate, and the purple line is the actual recruitment rates. And you can see that we are definitely on target because of the hard work of all people involved in the trial. So that's just a brief update. Thank you again to all of the REVIVE investigators, and looking forward to Graeme's talk.
Thanks, Dr. Wasserman. So in introducing, it is a pleasure of mine to introduce Professor Graeme Meintjes today. He's a distinguished physician, a scientist whose work has scientifically advanced the understanding and treatment of HIV-associated conditions. Prof Meintjes serves as a professor of medicine at the University of Cape Town, and he holds the position of clinical professor of infectious diseases at the Queen Mary University in London. With his research focus on the complications of advanced HIV disease, Prof Meintjes has led pivotal studies on conditions such as disseminated HIV-associated TB, TB-associated immune reconstitution inflammatory syndrome or TBitis, and cryptococcal meningitis. Beyond his research, Prof Meintjes has contributed extensively to the development and national and international guidelines on HIV, tuberculosis, and opportunistic infections. Please join me in welcoming Prof Meintjes today. He's also the REVIVE Steering Committee Chairman, whose expertise continues to shape the landscape of infectious disease research and treatment. Over to you, Prof Meintjes.
Thanks very much, Elsa, for the kind introduction, and thanks everyone for joining for the session today. Just to echo Sean's thanks to all of the investigators for your hard work in driving forward the recruitment to the REVIVE trial. So I've got about 50 minutes today to provide some feedback and really review some of the highlights from the recent conference on retroviruses and opportunistic infections that was held in the US in March. And this is the conference is termed CROI for short, and it really is the major scientific conference covering topics in HIV and opportunistic infections that occurs each year. Really, let me just move this forward to give you a sense of the scale of this conference. That it has almost 2,000 abstracts submitted, studies submitted, about 1,000 are accepted for presentations. We see that there's also late breaker presentations and about 100 oral abstracts and 1,000 abstract posters. And it's a huge challenge to summarize all of that in just 50 minutes. But what I've decided to do is just to focus on 10 studies that for me stood out, and I'm sure other people would have different opinions as to which to draw out of this vast array of important studies. But I'm just going to cover the 10 studies that stood out for me and provide a brief summary of each of those. But I'll start off by providing some context to the conference and then look at a study of drug-resistant TB transmission in South Africa, look at a study that looked at once yearly lenacapavir for PrEP, the CARES study, which is now out to 2 years of cabotegravir plus rilpivirine treatment, and look at a study that looked at intermittent bictegravir, FTC, and TAF, a study that looked at a switch strategy to doravirine islatravir, a Ugandan community study of people with HIV viremia, a study of dolutegravir resistance in Uganda, the issue of coronary artery disease in rural Africa, and end off with 2 studies that looked at broadly neutralizing antibodies in a cure strategy. And just to say that all of this, these presentations are now available freely online, and many of the slides that I've used in my presentation are screen grabs from those presentations, and just to acknowledge the presenters for that. But to start off with, just to provide some context, this conference obviously occurred in early March, and by that stage, the world was well aware of the incredibly negative and retrogressive actions that are being taken by the US government that threw a long shadow over the conference, the disbanding of USAID and the halting of PEPFAR funding, the withdrawal of funding towards HIV research, both in the US and internationally. And then in addition to that, the censoring of scientists that are employed with US government funding, that the NIH and the CDC, leading to many of them to have to withdraw abstracts or change the content of their work to fall in line with new US government policies that were seen as a form of censorship. And this really threw a long shadow over the conference. And in the opening session, Diane Havler, the chair of the conference, really reminded people of the incredible breakthroughs in HIV science and in the fight against HIV that had been enabled by scientific investment from many sources, but the US government being a major source of that funding over the last few decades, and what the perils of withdrawing that funding would be. And this slide just summarizes many of the huge impacts that the science has had in terms of prevention and treatment of HIV, but also that those fundamental breakthroughs have extended to other disease areas. And she also just showed some modeling work from Andrew Phillips at UCL to show, in the gray, what the reduction in HIV incidence among young adults globally over the last 2 decades, and the threat that the withdrawal of funding for antiretroviral therapy, as well as for preventative strategies like prevention of mother-to-child transmission and PrEP, access to PrEP, what the withdrawal of that would have in terms of its impact on HIV incidence. And you can see that there's a real threat that all of the gains could be reversed by withdrawal of funding. So to move on then to the 10 studies that I've selected to present today, the first was a study led by Neil Gandhi from Emory University. And Neil has done some important work in drug-resistant TB in South Africa for the last 2 decades. And this was a study looking at a community transmission of drug-resistant TB. And for background, the traditional teaching has been that close and prolonged contact is needed for TB transmission. But molecular epidemiology studies have found that there's only a link to 10 to 30% of genotypically clustered persons when the focus is on close contacts. So when one looks at household contacts, particularly of adults, only 10 to 30% can be accounted for by household contacts. And therefore, this study was undertaken to investigate whether casual contacts with limited interactions were contributing to transmission. And they focused on patients with XDR or pre-XDR, included 305 patients in their study, 71% were HIV positive. They conducted whole genome sequencing and then also did social network and geospatial data analysis based on information they collected from participants. And also use GPS coordinates to look for potential areas of contact between people who had linked strains. And so the methods were they obtained the culture isolates from the TB of these patients. They then genotyped them, and if the sequencing showed less than 12 mutations difference between the isolates, that was regarded as a linked cases. And among clustered pairs, they identified epidemiological links that were either close contacts or casual contacts. Close contacts were person-to-person link, for instance, in a household or having an overlapping hospital admission. Casual contacts were residential proximity of 1 kilometer, or community proximity spending time in the same place in the community for more than 2 hours, less than 500 meters apart, or shared outpatient clinic visits. And in terms of when they did the sequencing, they identified, they were able to sequence isolates from 251 participants, and 56% of those isolates were clustered, so that they were linked to another isolate. And there were 25 different clusters identified. The size of the clusters were either 2 participants, but one of the clusters was up to 48 participants in size. And then they overlaid that information about the linked clusters in terms of the sequencing data with the data that get collected on the social and contacts and the GPS data, and showed that those linkages were accounted for by 10% with close contacts, either household contacts or in hospital admissions at the same time. But far more were related to could be related to casual contacts. So contacts, about 50% had casual contacts. And you can see what accounted for the casual contacts was 68% attended the same clinic, 57% identified a linkage in a community setting, and 36% lived within 1 kilometer of one another. And obviously there was overlap between these 3 subcategories. So the implications are that casual contacts particularly among adults, have a major role in TB transmission in high burden settings. And when we think about preventative strategies, we need to think beyond household contact investigations and think about community level interventions for prevention, because a large proportion of transmission from this study could be documented to be happening in community settings. The next study I wanted to cover now looks at the issue of HIV prevention, and it looked at two novel preparations of lenacapavir. that could be used potentially for long-acting pre-exposure prophylaxis for HIV. And I just wanted to provide some background to lenacapavir before covering the study that was presented at CROI. So lenacapavir is a capsid inhibitor. It's the first drug in that class. And it interferes with the capsid-mediated nuclear uptake of HIV, and also the formation of new capsids when a new virus is being formed. So it acts at the uptake of HIV as well as the formation of new HIV particles to prevent HIV replication. And it's a long-acting drug. It can, the formulations of 6-monthly subcutaneous lenacapavir and weekly oral tablets. So also a background slide. This was the Purpose 1 trial that Linda Gale Becker led and was published in the NEJM in 2024, where it was a phase 3 randomized controlled trial of adolescent girls and young women in South Africa and Uganda, which evaluated lenacapavir every 6 months compared to 2 oral PrEP combinations, and then looked at the efficacy in terms of HIV prevention. And the findings were essentially, if one just looks at the graph on the right-hand side, the background incidence of HIV was estimated from recency assays at entry into the trial, and then compared to the 2 oral options on the right-hand side, the FTAF and FTDF. Lenacapavir, there were no HIV infections during the trial at almost 2,000 person-years of follow-up. And you can see that the rates, the incidence rates, the background incidence rates, and the incidence rates on the 2 oral combinations, and essentially 100% reduction in HIV transmission with lenacapavir 6-monthly subcutaneously. This was followed by the Purpose 2 trial that included cisgender, gay and bisexual, as well as transgender women and men. And it was a multi-country study, almost 3,000 participants. Again, looked at background incidence compared now to oral FTDF, and then lenacapavir in the middle. And you can see that there were 2 infections on lenacapavir in this study, but still a 96% reduction in HIV incidence compared to background, and an 89% compared to the oral PrEP option with no major safety concerns. So important background to the study presented at CROI is that 6-monthly subcutaneous lenacapavir is a highly effective HIV prevention strategy. So the trial presented at CROI was the first 2 points in the slide I've already referred to. The trial looked at a once-yearly lenacapavir administration, whether that could further the potential benefits of that are that it could reduce stigma, lead to better adherence and less frequent need for healthcare contacts among people who need PrEP. And when lenacapavir is injected, it forms a drug depot that is slowly released, leading to long-acting pharmacokinetics. And in the trial, they evaluated 2 novel once yearly, so single injection once a year of intramuscular lenacapavir, with an aim of achieving similar concentrations to twice yearly subcutaneous lenacapavir. And so this was an open label phase 1 study evaluating 2 formulations of 5,000 milligrams intramuscular dose of lenacapavir. The first formulation had 5% ethanol, the other one 10% ethanol. And they enrolled healthy participants at low risk of HIV, adults with a BMI of less than 35, and then observed the PK of the drug and the safety of the drug over the next year. And essentially what you're seeing here is the drug exposure over 56 weeks. In pink is the twice yearly subcutaneous lenacapavir that was used in Purpose 1 and Purpose 2. And in the purple is the once yearly intramuscular lenacapavir formulation. It's just showing formulation 2 here, but formulation 1 had very similar PK. And I'm not going to show you that, but essentially the concentrations achieved with a single intramuscular injection of lenacapavir were higher than what was achieved for the twice yearly subcutaneous dose, suggesting that this will also be effective for pre-exposure prophylaxis. And here you can just see the comparison of the trough concentrations between the twice yearly lenacapavir on the left, and then the 2 once yearly doses, intramuscular doses, achieving higher trough concentrations. And in terms of safety, both formulations were well tolerated and safe. There was mild to moderate injection site pain. Majority of participants, however, had no pain. And if they did have pain, it resolved after a few days. Unlike the subcutaneous injection, there were no injection site nodules. And you can see that with the 5,000 milligram dose, they achieved levels substantially higher than the 6-monthly dose. And so they will potentially evaluate lower doses in future studies. And a phase 3 trial is planned of annual injections. Just to say that this a study was published on the same day as it was presented in the Lancet. So to move on to the next study that I wanted to present was the week 96 results of the CARES trial, which took place in South Africa and Uganda. The week 48 results have already been published, but this was long-term follow-up. And this was a randomized trial of long-acting cabotegravir and rilpivirine as treatment of HIV. So the CARES trial was, we know that combination of cabotegravir and rilpivirine in prior trials has been shown to be effective as a switch strategy in treatment. But there were several unanswered questions, particularly about the use of that combination in Africa, where the majority of people have HIV, who have HIV-1 are African women, and the subtypes are different. There's high levels of NNRTI exposure and pretreatment resistance with NNRTI mutations. And the care and treatment strategies are different to what is used in Europe and North America. And so they had previously reported that the cabotegravir rilpivirine, long-acting every 8 weeks intramuscularly, was non-inferior to oral antiretroviral therapy at 48 weeks, but they now wanted to show the additional long-term data out to 2 years, with the aim of showing that switching to cab rilpivirine long-acting every 8 weeks intramuscularly was non-inferior to staying on oral antiretroviral therapy. And this is the design of the trial. Essentially enrolled adults who were stable on antiretroviral therapy, never having failed a prior regimen, and they were then randomized to stay on their oral antiretroviral therapy or to switch with or without a lead-in oral dose to intramuscular cabotegravir rilpivirine every 8 weeks, and then were followed out to the primary endpoint at week 48, and in this presentation out to week 96 or 2 years. And as I said, the study was conducted in sites in Uganda, South Africa, as well as Kenya, and very good retention out to 2 years, 98% retention. This is just the headline finding of the study, which shows that at 2 years, roughly 97% in both arms, so those who stayed on oral antiretroviral therapy and those who switched to the intramuscular cabotegravir rilpivirine, were suppressed to a viral load of less than 50, and switching was non-inferior to remaining on oral antiretroviral therapy. And this is just the conclusions, and picking up on some other points that were brought out in the presentation. That at 2 years, the cab rilpivirine long-acting every 8 weeks intramuscularly had high efficacy. 97% of patients maintained suppression. Only 4 patients had a virological failure. One of those patients died of an unrelated cause, but 3 resuppressed after switching back to oral antiretroviral therapy. And this was achieved in a public health approach with viral monitoring just every 6 months. And despite high rates of obesity that can interfere with the absorption, the intramuscular injection, and high rates of prior NNRTI exposure, potentially leading to cross-resistance to the rilpivirine and different subtypes, and provides good evidence that this would be a strategy if it was accessible in Africa. Obviously, there's major issues about the cost and accessibility to this option, but showing evidence of efficacy as well as safety with very few severe adverse events and mainly injection site reactions. And the majority of patients who were on cabotegravir or rilpivirine reported that they preferred that to the oral option. To move on to the next study that I wanted to talk about, this was presented as a poster and really just very preliminary pilot data, but sort of picking up on a strategy that could be considered should there be further data to support it. But really a pilot study looking at whether more intermittent dosing of an oral regimen could achieve similar efficacy to daily dosing. So the oral regimen that they looked at was bictegravir, FTC, and TAF, which is obviously very similar to our dolutegravir, 3TC, and TDF. Bictegravir and dolutegravir are similar drugs, FTC and 3TC are similar drugs, and TAF and TDF are prodrugs of tenofovir. So a similar combination, and this study was done in Spain, in Italy, and Spain. And what they did was they enrolled patients who were willing to take part and sign consent. 40 patients who were stable on and suppressed on this regimen, and randomized 10 of them to stay on daily dosing. 10 of them switched to dosing 3 times a week, 10 of them to dosing twice a week, and 10 of them to dosing once a week. And obviously, several of these drugs have long half-lives. The other important factor providing rationale for the study is bictegravir, like dolutegravir, binds to its active site for 2 to 3 days. And therefore, even once the plasma levels decline, the binding is still present. So potentially, it allows for intermittent dosing. And this was to evaluate proof of concept as to whether suppression could be achieved. And just to highlight the one table from the poster, and just to look on the right-hand side, at 48 weeks, the once daily dosing, so OD, there were no patients with a viral load above 50. All of those who had a viral load done were below 50. But you can see with the intermittent dosing 3 times a week, twice a week, or once a week, the majority of patients were still suppressed, 90%, 90%, and 70%. With intermittent dosing. So it's a small study. It certainly strategy could not be recommended with such a small study, but there is interest in taking forward this strategy potentially as a 3 times a week dosing of antiretrovirals, or twice a week, to see whether this could be a strategy that could be considered, and particularly as we face shortages with antiretroviral therapy. With global funding issues, if 3 times a week dosing was shown in a large study to be equivalent, that might be a strategy that could be considered. But as I said, this is just really proof of concept, early data that would need to be confirmed in a much larger study before it influenced practice. I next want to move on to discuss a study that looked at a strategy of switching to the combination of doravirine and islatravir. And I'll provide some background to it in the next slide. And it enrolled patients who were stable on the same combination of what I discussed in the earlier study, bictegravir, FTC, and TAF. And it was a phase 3 trial of essentially assessing the efficacy of this novel combination compared to staying on the 3-drug combination. So islatravir is a first-in-class drug from the nucleoside reverse transcriptase translocation inhibitors, or NRTTIs. And it has obviously works at a similar site to the NRTIs, but inhibits an additional step to the NRTIs in the reverse transcription process. And there's no cross resistance with the NRTIs. One of the problems with islatravir when it was used at higher doses previously for PrEP is that it caused lymphopenia, and that the further development of the drug was almost stopped, but then the decision was taken to look at a lower dose, which was had the potential to still be efficacious. And just by way of background, most antiretroviral therapy strategies are 3-drug strategies. But there is evidence for several 2-drug regimens, and this is additional evidence for an additional 2-drug regimen. But just for background, the evidence that we have to date is that the combinations that I've shown you there are 2-drug regimens that are non-inferior to 3-drug regimens, like combination of lopinavir, ritonavir, and efavirenz, which is obviously poorly tolerated, dolutegravir plus 3TC, dolutegravir plus rilpivirine as a switch strategy, dolutegravir plus darunavir, ritonavir from the DEFT study, and then the long-acting intramuscular cabotegravir and rilpivirine that I discussed earlier from the CARES trial and other trials. So this study was a double-blind study that enrolled patients who were stable on bictegravir, FTC, and TAF. They had to have certain criteria with respect to their CD4 count, total lymphocyte count, no history of having previously failed a regimen, and they were randomized to switch to just a 2-drug combination of doravirine and islatravir. Doravirine, I haven't mentioned, is a second-generation NNRTI. Islatravir is the NRTTI. And or to stay on their big FTC and TAF. And what they presented at CROI was the 1-year or week 48 results. And you can see that at the week 48 visit, that 91% or so of people on the doravirine islatravir were still suppressed, and 94% who had stayed on their big FTC and TAF were suppressed. And doravirine and islatravir met the criteria for non-inferiority. So similar rates of suppression maintained with this 2-drug combination. And among those participants who did, the 2 participants who did have a viral rebound, no resistance to doravirine or islatravir was detected, and they were able to resuppress. They didn't observe any problems with respect to the total lymphocyte count at this lower dose that was used, and no substantial differences in CD4 count either. So the conclusions from this study was switching to doravirine islatravir was non-inferior to continuing BIC, FTC, and TAF, people living with HIV who were virologically suppressed. And there was no resistance to these 2 drugs observed, generally well tolerated, and didn't affect the total lymphocyte count or CD4 count adversely. And important to say that, compared to these previous 2-drug regimens, all of them had contained either a PI, protease inhibitor, or a integrase inhibitor, whereas this is the first 2-drug combination that has been shown to be effective that just targets reverse transcriptase. Obviously there will be further studies done. One other study looking at this combination was presented at CROI that I'm not going to show you. But this does provide an additional option. What its role would be in international treatment programs is unclear. I don't think that it would necessarily take the place of TLD, but just for individualized therapy settings, it might have a role. Then to move on to a study that was presented from Uganda that looked at the issue of people living in communities who have a detectable viral load, who are not suppressed on antiretroviral therapy, to try and understand what the factors contributing to that phenomenon are in the era of widespread antiretroviral therapy. So this was a population-based study done in Rakai in Uganda. where they asked people between the ages of 15 and 49 to enroll. They approached people in 34 communities, fishing communities and farming communities between 2020 and 2023. HIV testing was done, viral load testing was done, and if patients had a viral load of over 1,000, then ARV drug testing was done on their blood sample as well. And they also did survey questionnaires. So this just shows you the enrollment and the categorization of the people who participated. So they enrolled 17,000 people, just over 3,000 were found to be HIV positive. And then 10% had HIV viremia with a viral load of greater than 1,000. Among those with viremia, 54% were newly diagnosed, 10% reported that they had never been treated, 33% were in care, and just 3% reported that they had previously been in care. And then they did the resistance testing and the drug level testing, and they invited people back for another interview. And based on the re-interview, the clinical, looking at their clinical records and looking at the drug testing, they then reclassified people with all of that information and found that 30% of people were reclassified differently to what they had initially reported. 49% of those who said that they were in care and currently on treatment, many of those had actually disengaged from care and were previously on treatment. And among 20% who said that they had a new diagnosis were found to have that they had previously been diagnosed but had never started treatment. And so the final conclusion was that 83% of people with viremia, so with a viral load of over 1,000 in the community, were not in clinical care. And most of them had never initiated treatment, which is different to a setting in South Africa, where we find that many of those people in the community with a high viral load have previously been on care and have interrupted treatment. But here, many people had been diagnosed and had not started treatment. So I think that, the message from that is it's understanding why people are still living in our communities with viremia, without a suppressed viral load, despite access to antiretroviral therapy is complex. It's a combination of people who've newly diagnosed, who never had a diagnosis previously, people who were diagnosed but never started treatment, and then people who started treatment and interrupted. And on an initial interview, you might not get all the information, but getting access to records and testing for resistance and for the presence of antiretroviral drugs in blood, you get a complete picture to understand the situation. Then just briefly, a poster presentation, this one also from Uganda, which looked at the issue of resistance to dolutegravir in a community setting. And this was in the REVIVE community cohort study. And they looked during the period of dolutegravir scale-up from 2014 till 2022. What they saw that during the period of dolutegravir scale-up, they observed a decrease in resistance to NNRTIs and NRTIs, but a continued increase in NNRTI resistance among people entering care with the pre-treatment resistance test. And so just to show you one or two of the tables from this poster, and I think this tells an interesting story because it's showing you the proportion of people with suppressed HIV in REVIVE over the period 2014 to 2022. And you can see it goes up from around 50% or mid-50s to 90% over that 8-year period, which is really a remarkable achievement. And just, based on what I was saying right at the beginning about the withdrawal of funding, it's terrifying to think that this incredible progress might be reversed. So what I think has led to this increase in community viral suppression is a combination of the change in policies to allow treatment for all people with HIV, regardless of CD4 count, around 2016. That was preceded by gradual expansion of criteria, and then the transition from efavirenz to dolutegravir, which is just leads to a far more effective antiretroviral therapy regimen. And then the specific focus of their study was to look at resistance, and you're seeing the different classes. Just to highlight NNRTI resistance in the triangles, that's continued to go up, which is quite surprising with the reduction in efavirenz use, that you're still seeing so much NNRTI resistance. But I think it's just the story that NNRTI resistance does hang around even when the drug is stopped and continues to be transmitted, because it doesn't have a fitness cost like other drug class resistant mutants. Whereas the other message here is that resistance to integrase inhibitors like dolutegravir remains strikingly low in the orange circles. And then if we look at emergence of resistance in people on antiretroviral therapy who have a high viral load, you can see that in orange, in the left-hand graph, resistance to the integrase inhibitors like dolutegravir remains very low, much less than 5%, whereas the resistance to the other classes is coming down to the NNRTIs and the NRTIs. And so that's good news with the introduction of dolutegravir in our programs, that we're seeing low resistance to dolutegravir and less resistance to drugs in other class because it's being protected by the dolutegravir in the regimen. Then again, another study from Uganda, but just on a different topic. This is on the issue of coronary artery disease among people living with living with HIV, sorry, in Uganda. And the context to this is that in Europe and North America, people with HIV it's well documented. Several studies have shown that there's more than twofold increased risk of coronary artery disease, even if people are on effective ART. There's very little data from this on Africa. And some of the modeling studies that have been done have used the information from North America and Europe and transposed it on African HIV populations, and predicted that there will be an increase in coronary artery disease. And of course, there are huge limitations in an approach like this, because one really needs to go and gather data within Africa to really understand whether one is seeing the same phenomenon in Africa, an increase in coronary artery disease among people living with HIV. And this is exactly what these researchers did. They assessed the prevalence of coronary artery disease in rural Uganda in people over the age of 40 who were living with HIV on antiretroviral therapy versus matched controls in the same community without HIV. And they used contrast CT angiography to estimate the prevalence of coronary artery disease. This was not a study following up people to ascertain incident cardiac events. It was a cross-sectional prevalence study. Just important to point that out. And the main research question is treated HIV associated with an increased prevalence of coronary artery disease among people over the age of 40 in Uganda? And this is just summarizes the method. So they enrolled people with HIV who were attending the clinics, who were over the age of 40, had been on ART for more than 3 years, and had normal renal function because it involved angiography. And then they enrolled matched controls of people without HIV from the same communities, matched for age and sex. It was done in Mbarara, so it involved transporting people to Kampala for a CT angiography to assess for coronary plaques and calcified plaques, as well as questionnaires, phlebotomy, and other clinical measures. And the profile of people with HIV included in the study, median age was 58, 95% had a suppressed viral load, 50% had a CD4 above 500. Median years on ART was 8 years, about 15 to 20% had hypertension and 8% diabetes. And this is the headline results, is that among the total cohort, 9% of those people living with HIV had evidence of coronary plaques on angiography, compared to 6% without HIV, and that was not statistically significant difference. So 3% difference. That one can debate what the clinical significance of that, but it was not statistically significant, and not the twofold or greater increase that has been seen in other settings. And then, but predictably, as the atherosclerotic cardiovascular disease risk score increased, so did the risk increase, but it increased similarly in HIV, people with HIV and people without HIV. And just then they showed this slide to contrast their data on the right-hand side in the bright orange, the Ugandan data from their study with population prevalence studies of coronary artery disease in other settings. And you can just see in rural Uganda how much lower the prevalence of any coronary plaque on CT angiography is, and any non-calcified plaque is much lower than other settings. And just for those of you who've not used to this kind of measure with the CT angiography looking for plaques, is several other studies have shown that it is it does have the capacity to predict subsequent cardiovascular events. So it is an established way to ascertain the prevalence of coronary artery disease and predict later coronary events. And so, the conclusion is essentially the prevalence of coronary artery disease among people with and without HIV in Uganda was substantially lower than other global populations. And they did not detect a meaningful difference. So the 3% difference was not statistically significant between people with and without HIV in that setting. But they do highlight that there's, non-infectious comorbidities are going to be an important cause of morbidity and mortality among people living with HIV as they age with HIV in Africa. But those might be different to North America and Europe. There might be a need to focus on things like heart failure and stroke, which are obviously more common in Africa than coronary artery disease. And then in the last 10 minutes or so, I just want to focus on the last two studies. And both of them were studies that are essentially were early kind of pilot proof of principle studies focusing on HIV cure strategies. Now, there's a whole field of research within the HIV science community that's focusing on whether a cure for HIV is possible. Obviously, we have effective treatment, but that means taking a tablet lifelong or getting an injection every few months. And in order to really sort of provide effective treatment towards a cure would take a very different approach. And in that field, there are three possibilities conceptualized. The one is a complete cure, which would involve eradication and complete elimination of the virus. And of course, that has been done, for instance, with Timothy Brown, the Berlin patient, and several subsequent patients who've had bone marrow transplants with CCR5 deletion and have successfully been cured of HIV, but that's not something that could be replicated in any sort of widespread approach. What's more realistic is a functional cure, which means that there is still HIV present, but its replication is controlled. And then remission, similar to the cancer field, which means that HIV is controlled without treatment, but one still needs to monitor because it could rebound. And the strategies that are being looked at in this field are strategies that involve latency reversal. So essentially causing activation of those cells that contain the HIV reservoir, causing them to start replicating HIV, and then relying on the immune system or various immune strategies to eliminate those cells that are essentially woken up from their latent state and producing HIV. The reverse strategy is what's called the block and lock strategy to drive the HIV reservoir into a more permanent state of latency. There are various gene therapy approaches that are being looked at targeting the cell entry of HIV into cells, for instance, targeting the CCR5 receptor or targeting HIV sequences within the reservoir. And then immune-based approaches, which involve broadly neutralizing antibodies, CAR T cells and NK cells, and then a combination of these approaches. And the two studies that were presented at CROI were both focused on the broadly neutralizing antibody strategies. So broadly neutralizing antibodies are antibodies that have been isolated from people that have lived with HIV for several years and are not just able to neutralize their strain of HIV, but have activity across the majority of strains of HIV that are recognized across the world, obviously in laboratory experiments. And then through recombinant technology, producing those particular isolated antibodies to be used in prevention and therapeutic strategies. And so the one study was the RIO study conducted in the UK and Denmark. There was a randomized placebo-controlled trial of two broadly neutralizing antibodies in patients treated in early HIV. And their question was, can two broadly neutralizing antibodies maintain viral suppression of antiretroviral therapy compared with placebo? And if they do, for how long? And so they enrolled people who living with HIV who were on antiretroviral therapy and started early in their HIV infection. And they had been suppressed on antiretroviral therapy for at least 12 months. Their enrollment CD4 count has to be greater than 500, and they were willing to access PrEP and appropriate protection to protect their sexual partners. And the exclusion criteria are shown there. And so they enrolled 68 participants, and they were randomly allocated. All of them interrupted antiretroviral therapy. It's called an analytical treatment interruption. And then half of them received the two broadly neutralizing antibodies in the blue. And then the other half in the red received a placebo. And then they were followed for the first 20 weeks to see what proportion of participants had rebounded. And if they remained suppressed, then there was the option for a second dose that remained blinded, and to follow them up for additional time to look at how long suppression was maintained. And this is up to the 20 weeks. You can see in blue is those participants who received the broadly neutralizing antibodies, and in red is those who received placebo. And what you see is that among those who received placebo, by 20 weeks, 90% had viral rebound. So stopping antiretroviral therapy leads to the virus rebounding in the blood, whereas among those who received the broadly neutralizing antibodies, only 25% had rebounded and 75% remained virologically suppressed. They then, if they remained virologically suppressed, received a second dose. And let's just focus on in the blue, those who received the broadly neutralizing antibody, is that the median time to rebound was 62 weeks. 57% had not rebounded by week 48. And 39% had not rebounded by week 72. And essentially, this showed that the broadly neutralizing antibodies were able to maintain viral suppression even beyond the time period that the drugs were still therapeutic within, because they only remain at levels above their inhibitory concentration for about 24 weeks. So there was long-term suppression. And in posters that were presented around this study as sub-studies, they showed that giving broadly neutralizing antibodies led to a reduction in the size of the proviral reservoir, that was the competent proviral reservoir, and also had effects on the CD4 and CD8 responses to HIV, a kind of vaccinal effect that probably led to the long-term containment beyond the second dose of the broadly neutralizing antibodies. And then the final study was also a study looking at broadly neutralizing antibodies done in South Africa, in Durban, led by Tumbi Ndungu. And this looked at two broadly neutralizing antibodies together with a drug called Vestolimod, again in people who were treated early during HIV, and then looked at the effect of this strategy during an analytical treatment interruption. So this involved 20 participants from the fresh cohort in KZN. These were women who were treated early during antiretroviral therapy. The median duration from HIV diagnosis to antiretroviral therapy was 1 day. This was obviously historic. They'd been on ART for 7 years, and if they agreed to participate, they had an analytical treatment interruption. They received 1 dose of 2 broadly neutralizing antibodies that are shown there, and then 10 doses of TLR7 agonist, which stimulates the antiviral responses of the immune system. And then their viral load was intensively monitored. And that's just showing the design of the trial. And the primary endpoint was around safety. The efficacy, and then efficacy endpoints included time to virological rebound. That's the PK of the 2 broadly neutralizing antibodies. You can see by around 20 weeks, the broadly neutralizing antibodies drop below the inhibitory concentration predicted. And they identified 3 distinct patterns of viral rebound in the participants, in the 20 participants. In the first group, there were participants who rebounded rapidly. In the second group, there were participants who had a rebound only once the antibodies started to decline below the inhibitory concentration. And then in the third group, there was who were essentially people who had post-treatment control, with 6 out of the 20 remained off ART for 1 year, and 4 out of the 20 remained off ART for the whole study out to 55 weeks. And the 4 controllers opted to remain off ART, and they remain off ART for 1.5 years now, which is surprising because that's a higher rate of suppression than one would expect for people usually interrupting their antiretroviral therapy, which is expected to be about 4%. And so this was the first HIV cure strategy trial done in Africa, which showed that this combination was safe and well tolerated, and that 20% of participants remained off antiretroviral therapy with viral control, and another 40%, although they rebounded, had an atypical rebound dynamics where they rebounded and suppressed again and then rebounded again, suggesting that the antibodies are having some effect on the immune control of HIV after interrupting antiretroviral therapy. So these 2 cure studies, I just wanted to put up one slide that summarizes them. They're essentially proof of concept studies that involved analytical treatment interruptions, enrolling people stable on ART, having them interrupt their ART, being monitored closely, and then intervening with a strategy that could potentially control their HIV after interrupting antiretroviral therapy. They both involved using 2 broadly neutralizing antibodies. One of them involved also a TLR7 agonist. And more participants maintained suppression than would be anticipated when you interrupt antiretroviral therapy and monitor people, suggesting that there was some effect on viral rebound. Obviously, this is very early information. It's not going to be converted into practice because one would have to achieve far better results for it to be a potential strategy. But I think what these investigators will learn is about the mechanism for interruption, the mechanism for control of HIV replication after interruptions, and then be able to build the science based on this to work towards strategies that could allow people to interrupt their antiretroviral therapy and achieve immune control. And then just the final slide to just recommend this lecture that was given by Rebecca Dennison, the Martin Delaney lecture, which is given every year by a member from the community who sort of gives a perspective from the communities affected by HIV and the activist community on HIV at the start of CROI. And Rebecca Dennison was the founder of an organization called Women Organized to Respond to Life-Threatening Diseases. And she spoke about that organization, but also her personal experience of having lived with HIV, having been diagnosed in 1990 when there was no therapy available, having joined the activist community as one of the first women to join the HIV activist community, and having lived through the struggle to drive the science and the role that the activist community played in driving forward funding for HIV science, and driving the scientific agenda in HIV, and seen the successes that have been achieved, and then also obviously spoke about the terrifying situation that we find ourselves in with reversal of many of those achievements and the funding that supports the HIV science and HIV programs globally. So I would strongly recommend this, and really her life story is a very important one, and one that provides very important perspective on the HIV story about how she lived through the terrifying experience of being diagnosed with HIV, going on to treatment and living a healthy and fulfilled life with antiretroviral therapy, and her story as an activist. And with that, I'll close off, and thanks very much for attending and for your attention.
Thank you very much, Graeme, and thank you for everyone who's joined. Just in the interest of time, and for those who need to log off, are there any questions that you want to pose to Prof Meintjes?
Can I ask a question, Elsa?
Yes, you can, Dr. Boyles.
Yeah, Graeme, yeah, just the once yearly lenacapavir is fascinating and hopefully a genuine game changer. Just I wonder what you think about the ethics of vaccine research now, not in terms of the studies that we can do. Would it be even possible to do a vaccine study without giving the control group? Well, I mean, I'm just jumping forward to assume that once yearly lenacapavir is efficacious in a phase 3 study, but even currently with 6 monthly, would it be even ethical to do a vaccines trial without giving them this type of protection, which is close to 100%, and therefore how will we know if any vaccines work?
Yeah, Tom, excellent question. I think that you know that issue of the control arm in HIV prevention strategies has been something that's been on a key issue in the HIV prevention field for 5 to 10 years, as we've got better and better strategies, what you use as your control arm. And vaccine studies that have been done have offered participants oral prep, but now obviously with the lenacapavir have been shown superior to oral prep, they will have to potentially offer lenacapavir as well. So that does make it very difficult, to conduct those studies. And one of the things is that people might not want to take the lenacapavir, but that seems very unlikely if they're willing to participate in a vaccine study. So I think it does throw the ethics of vaccine studies into a considerable and the design of vaccine studies into a considerable question mark going forward. I would agree.
Thank you.
I don't see any other hands. If there are any more questions, you are welcome to forward them either to myself or directly to Prof Meintjes. And then there was a caption in the chats that said, "Congratulations, remarkable amount of work to put together." And yeah, we want to say thank you to Prof Meintjes for this excellent presentation. I know that he's a very busy man, but this was really insightful. And I will ask whether we are allowed to share his slides, and then we'll also share the link to the YouTube video that he suggested. Thank you everyone for joining. And just quickly before you drop off, I just wanted to mention that the next seminar is on the 27th of May, and you will receive an invite to a presentation by Professor Lahana Thabani from the McMaster University in Canada. And this will be on the key concepts in modern clinical trials, covering non-inferiority and adaptive designs and platform trials. We'll reach out to all of you shortly and just send that link. So thank you, everyone. If there's nothing further, we can drop off, and you must have a very nice day.
Thanks, everyone. Bye-bye.